Hi everybody, we're just waiting for all the registrants to be able to join and get online to be able to see us, so give that a couple of seconds, make sure that everyone can hear us. Okay, great, so welcome to this webinar. It's my privilege to be able to say thank you and welcome to all of you, and thank you to our speakers and colleagues that have brought this event together. I am Joanna Travis-Roberts, the Chief Executive of ISSUP, and ISSUP is the International Society of Substance Use Professionals, which is a membership organisation spanning with members from all around the world, and we currently have over 14,000 members, and we're really here to build, connect, unite and support anybody who is undertaking work around their prevention, treatment and recovery support for the substance use disorders. So we're really here to put you all on the map as a very hard-working, essential workforce, and to build the connections, the networks, and increase the knowledge within this workforce. And as an organisation, our vision is a connected, trained, knowledgeable and effective international network of substance use prevention, treatment and recovery professionals, undertaking and promoting high quality, evidence-based and ethical substance use prevention, treatment and recovery support. And you know, this is very much the mood of this webinar, in terms of really focusing in on that evidence, and we're really proud to be part of a series of webinars like this. The way that ISSUP works to achieve that vision is in three ways. We work digitally, so we have knowledge sharing online, we have networks and connections that we're building online, webinars like this, as well as all of our social media and email communications to build and support the field. We have national chapters, which is where our mission is delivered within the country's context, language and culture. So that's really our key way to understanding the needs of the workforce and supporting you all. Plus our events, which we used to enjoy having those face-to-face. At the moment that's on hold and we're doing everything digitally, but it's still a fantastic way to bring people together and support that awareness and knowledge building. So as I said, I'm really very privileged to be opening the second in really a landmark series of webinars that are brought to you by ISSUP Nigeria. And I will stop talking about us and hand over now to the president of ISSUP Nigeria, Dr. Agwogi, and who is a member of the ISSUP board as well. So you're in very good hands. He's an esteemed colleague and friend of the organisation. And all that's left for me to say is thank you very much for listening today, and good luck to all of you for the webinar.
Thank you very much, Joanna, for your kind words. We really appreciate your support. Thank you once again. Good morning, good afternoon, good evening, depending on where you are joining us from. On behalf of the members of ISSUP Nigeria chapter, it is my pleasure to welcome you to this second session of ISSUP Nigeria bi-monthly webinar, tagged ISSUP Nigeria Knowledge Update Series. We are excited to have you join us in this session, and we say you are welcome. The webinar series is in line with our mission to build and support the capacity of drug demand reduction practitioners in Nigeria to deliver evidence-based substance abuse prevention, treatment, and be able to contribute to drug control policies. Our next session will hold on Thursday, the 26th of November 2020, and we do hope you will make our time to join us again. Today, we shall be discussing a very important topic in the field of substance use prevention, treatment, and recovery, which is relapse and relapse prevention. We have a very experienced colleague who will be leading us in this discussion. By way of introduction, just in addition to what the introduction by Joanna, I am Martin Agoje. the National President of ISSUP Nigeria chapter, and I will be co-moderating this session. To join me in moderating this session is my colleague, Dr. Bawo James. Bawo is the Public Relations Officer of ISSUP Nigeria chapter. So Bawo, you are most welcome.
Thank you very much, Martin.
So at this point, let me hand over to Bawo to take it up from here and to introduce our speaker for today. Thank you.
Thank you and welcome everybody. I will introduce the speaker today, and she is Dr. Olajumoke Mosunmola Koyejo. She's a medical doctor. She's been a doctor now for the past 17 years and is also specialized in the field of psychiatry. She obtained her Bachelor's of Medicine and Surgery from the Obafemi Awolowo University in 2003. And then she completed her specialist training in addiction in psychiatry, I beg your pardon, from the National Postgraduate Medical College in 2012, and received further specialization in addiction from the Fulbright Scholarship Program as Substance Abuse Prevention, Treatment, Education, and Policy from the Virginia Commonwealth University in the USA. There she also had certifications in tobacco prevention and treatment, protection and evaluation from the Ontario Tobacco Research Unit, and the Center for Addiction and Mental Health at the University of Toronto in Canada. She also had additional qualification as an international certified addiction professional from the GCCC and also from the International Center for Credentialing and Education of Addiction Professionals in the US. Dr. Koyejo currently works as a consultant addiction psychiatrist at the Center for Addiction Treatment, Education and Research and Advocacy at the Neuropsychiatric Hospital in Yaba, Lagos. And in the hospital, she's also a national coordinator and an international trainer in substance use treatment for the Colombo Plan Drug Advisory Program. And to this end, since 2017, she has facilitated training of over 300 addiction professionals in Nigeria. And I was also participated in training of addiction professionals outside of the country. During her international studies, she has had her horizon broadened with respect for detail, and the wide knowledge base has placed her at an advantage to treat a wide range of patients and clients. And her ability to see challenges as an opportunity to learn, her analytical mindset and efficiency has also placed her in a position to adapt evidence-based processes into her clinical research and training practice. So I believe that the audience today will definitely benefit from the topic on from treatment to relapse. So Dr. Koyejo, over to you.
Yeah. Thank you very much, Dr. Bawo. So I'll be talking, good afternoon, good morning, and good evening, everybody, depending on where you're listening to us from. I'll be talking on the topic from treatment to relapse. Well, I work in the Federal Neuropsychiatric Hospital, Yaba, and that's one of the foremost psychiatric hospitals in Nigeria. Okay, and I'll be speaking on it under this short-term content. Yeah, by way of definition, what's relapse? I'll give a very streamlined definition and a broader definition that includes all other addictive behaviors. But for substance use disorder, relapse is the reoccurrence of substance use disorder symptoms after a period of reduced or abstinence of substance use. While for other addictive behaviors, relapse is a setback that occurs during a behavioral change process, such that progress towards the initiation or maintenance of a behavior change goal is interrupted by a reversion to the target's behavior. That's by way of definition. Okay. Relapse prevention is why most people seek treatment, and that's why they come to us as experts to seek treatment. Most people seek help after failed attempts, and they are simply seeking for better solution than their own attempts. I'll tell you that relapse is a gradual process with distinct stages. Motivation waxes and wanes. The goal of the therapist and the client in treatment is to help individuals recognize the early stages of relapse at which outcome of intervention is best. We all know that prevention is better than cure. So for us as experts, our goal is to let the clients know that, look, you are moving away from your recovery, you are at the early stage of relapse, and there's need for you to reverse back to that stage of maintenance in which you can't continue your path of recovery. I'll talk about recovery as a process of personal growth. Thus, it has its own developmental stages, milestones. Every stage of recovery has its own risk of relapse. So it's a journey, and sometimes it's a lifetime journey. Relapse begins weeks to months before an individual actually picks up the drink or the substance to use. So the simplest of it is when the final picking up of the substance to use. But most times, relapse has started months, patients have relapsed months before then. And that's why we want to know what are the things happening in the brain that would cause that, that final stage of picking up the substance. As professionals, of course, we know we can't follow our clients everywhere they go to, but we need to empower them with skills to be able to say no, the skills to be able to continue on that their path of recovery. And that's why, and that's the help they are seeking. The prevalence of relapse generally is between 40 to 75% for heroin and other illicit substances within 3 months of discharge from treatment. And 12-month relapse rate can be, for alcohol or tobacco, can be as high as 80 to 95%. So now, you've discharged the patient. What factors influence relapse? It is important for us to know, as to re-emphasize to other professionals, that relapse, one size does not fit all in relapse prevention. So you tailor it according to the client's needs. Identification of patients and their unique biopsychosocial characteristics, who they are, their environment, their thought pattern, that are associated with relapse would help in adjusting their relapse prevention programs for better outcomes. So now, these factors that influence relapse, because relapse takes different routes in different individuals, the strategy to use in men is different from the strategy to use in women. Adults have their own unique relapse experience, which is different from adolescents. So the way you deal with relapse prevention in adults will be different from what you do in teenagers. Relapse for different substances, the route for relapse for different substances is different. So there's need for us even to tailor it according to the substance of use. And relapse prevention strategies that we should consider, even pre-treatment, treatment, and discharge, they are quite different from each other. So there's need for us to have great knowledge of relapse prevention so that we can tailor it to that our clients need. So let's go to some of these factors that affect relapse in adults. In adult, intrapersonal space is very important. Most adults would relapse is actually with anger or frustration. That's negative intrapersonal states. And increased relapse, there's increased risk of relapse when coping with urges and temptation to use. In the presence of the cues, the risk of relapse is 2 times when the cues are absent. And negative psychological states, maybe mental distress, would always have high risk of influencing relapse in adults. However, things like interpersonal conflict and social pressure have less risk of causing relapse in adults. What are the factors that would cause relapse in youth? Of course, these things are not cast in stone. There might be need for us to actually adapt to, there might be need for us to teach everybody's basic things and re-emphasize based on their age group. So in children, in youths, what are the factors? Social pressure, that's outside pressure, actually is a big factor in young adults and youths that causes relapse in them. Enhance a positive mood. Let's enhance that party mood. I'm happy today, let's enhance it. These are factors that would lead to relapse in youths. Temptation in the presence of cues too, it's another factor that would increase relapse in youth. So you can see that in adults is their own intra-space, while in youth, it's outside pressure that affects, that has higher risk of relapse in them. So let's go to pre-treatment psychological factors that we should consider. When you see a patient, even at assessment, there's need for you to even look at factors that patient is bringing in. Under-recognized or poorly or inadequately treated mental distress leads to poor patient outcomes. So we're not just about, we should not just focus on the drug alone. What about the other psychological distress, mental distress this patient is going through? How do we help this patient out? These are the things we should look out for even at assessment. Level of internal or intrinsic motivation, which is pre-treatment intrinsic motivation, though it's associated with relapse in alcohol use disorder, while it has no significant pre-treatment difference for other substances. Let me explain what this means. That means external motivation, our patient might not have any internal motivation at assessment. So it doesn't have any, science has shown us that it has no significant pre-treatment difference. That once the patient comes to us, even if it's through law enforcement agency or through the school and appears before us, we should grab that opportunity to go ahead to treat. Presence of comorbid psychiatric disorder. These are pre-treatment negative emotional states such as anxiety and depression. These are factors we should consider which could affect outcome of relapse prevention. Treatment services and treatment environment factors. Well, when I teach, I tell people that some rehabilitation centers are like 7-star hotel or poultry. You just put them there, enjoy yourself and go. They're not actually offering treatment. So the length of stay is associated with increased risk of relapse. So the higher the length of stay, the decrease the risk of relapse. And standard is even telling us 6 months. People that would spend below 6 months, they are at higher risk. However, it's not just about the length of stay. The intensity, the quality of treatment you offer this patient is important. So when you take the patient and you treat him as if he's just in a 7-star hotel, no treatment, and you feel that just putting the person there, it's enough, it might not achieve the outcome you desire. Reduced risk of relapse is associated with completed treatment programs. That means people that discharge against medical advice that didn't come, it's associated with increased risk of relapse. Relationship of treatment staff with clients. Though not going beyond ethical limits, we should have good rapport with our clients. It would actually affect their treatment, their relapse prevention outcome. High level of activity and patient involvement in treatment programs is associated with better outcomes. So we should actually encourage our clients, even when they are in residential treatment or even outpatient intensive care treatment, to be involved in what we are doing, because these are the factors that would affect their relapse prevention and outcome. Planning for further recovery initiatives such as support groups, housing and employment during treatment. Post-treatment planning, post-discharge planning during treatment is actually very important, which would help in the outcome of treatment. Studies have also shown that commencing the support group programs actively during treatment would help patients continue post-treatment. And these are factors that would help outcome of relapse prevention program. So while they are during their treatment, they should start their support group so that they can continue, to encourage them to continue while at discharge or outside. So after discharge, what factors do we tell our patient? What factors do we emphasize to them? Peer pressure has been shown as the commonest cause of relapse. Poor follow-up. So don't think so. We should tell our client that yes, we've been discharged from this intensive care. It is not for you to now to go and fold your hand and feel that yes, everything is over. There's need for proper follow-up. Absence of self-help groups could also lead to poor outcome despite good treatment duration and intensity. So follow-up support group are factors that we should consider, and we should emphasize to our clients that, look, this would help you to stay in recovery. So let's talk about general factors that would influence relapse. When our patient with sleep disturbance, the tendency for them to relapse is very high. Poor literacy level, unemployment, long duration of use is associated with increased risk of relapse. Early age of onset, younger age associated also with increased risk of relapse. So let's talk about principles of relapse prevention. Cognitive behavioral therapy. Believe that when there's a change thinking pattern, the action would change. So it's the brain that coordinates the action. Then we should teach our patients healthy coping skills. I tell my patient that, look, you are in school. You are in school not to learn maths and English or literature. You are in school to learn coping skills. You are in school to learn ability to say no. And development of mindfulness-based relapse prevention, these are principles that are used in relapse prevention. Now, other things we should tell our patients are stages of relapse. There are 3 stages of relapse. There's emotional relapse, there's mental relapse, and the eventual physical relapse, which is the picking up of the substance to use. So emotional relapse, what happens during emotional relapse? It is characterized by poor general care, poor emotional care, poor psychological care, and poor physical self-care. So what things do patients do at this time? So clients would definitely remember their last relapse and they don't want to repeat it. So they are not actively thinking of using. In fact, they think of, no, I don't want to go through that again. So they believe they are on the recovery path. However, with this acronym of HALT, which is hungry, angry, lonely, and tired, the patient has bottled up emotion. They are isolating themselves. They are not seeing life outside of that drug use. Neglecting or not exploring hobbies or other positive things of life. Not seeing life outside of drug use. And when they are bored, emotionally, they are on the path to relapse. They have missed follow-up appointments, meetings, or not participating in their support group. They focus on others, on how they made them use or pass relapses, or focus on other people's problems. There's poor self-care, eating, and poor sleeping habits. These are signs of emotional relapse. So when we tell our patients all this, that look, when you start experiencing this, you are on the path of relapse. So if we've empowered them with this knowledge, by the time they start getting bored, they start thinking about life within that circle, they quickly tell themselves that, look, I think I've left recovery, I'm on the pathway. And so it helps them to be able to say, look, what is the intervention? So what's the intervention for emotional relapse? This emotional relapse is just in the head, but the patient would have relapsed. Self-care, taking care of themselves. Help clients know what it means and how important is this. This can be as basic as physical care, such as sleep, good hygiene, and healthy diets. Most individuals need more of emotional self-care, so they might need emotional support. Clients need to make time for themselves and to be kind to themselves and to explore hobbies and do other fun things, and they should be happy outside of that, their drug using habits. Outside of that, their drug using cycle. So what are the interventions for emotional relapse? Continue. We should ask questions like, are you starting to feel exhausted again? Do you feel that you are being good to yourself? Are you having fun? Are you putting time aside for yourself? Or are you just getting caught up in life? I tell people we should have that selfish time to ourselves. I mean, selfish time for your own self-care, selfish time for your own, to think about yourself. I know that, yes, I am who I am. So let's go on to mental relapse. So if the patient does not, if we don't empower our patients with that knowledge of emotional relapse, they move on to mental relapse. And what happens there? This feeling builds up into prolonged and poorly addressed emotional relapse leads to feeling of restlessness, becoming irritable and discontent. This feeling builds in tension and there's need to escape. There's need to escape that tension that has been built in. Mental relapse is a state of contemplation that is whether to use or not to use. With no intervention, cognitive resistance to relapse decreases and the patient might end up going to use. So what are the signs of mental relapse? Craving for drugs or alcohol commences. I feel like using. Thinking about people, places, and things associated with past use. Minimizing the consequences of past use. Well, actually, it wasn't as bad as the doctors are talking about it. The complications, I can still manage it. Then they glamorize their past use. Wow, the euphoria they felt. Bargaining, they start bargaining in their head about the advantages and pleasure of use and not to use. They think of acceptable scenario of use. Well, maybe I should use in this place, maybe I should not use. So bargaining can be people thinking about they can relapse periodically in a controlled way. So they feel okay, maybe they can relapse once or twice a year. Or can switch from one purportedly dangerous addictive substance to a less dangerous one. They start bargaining in their head and what else can I do? They start lying to themselves, thinking of schemes to control, to better control use. That well, even if I start using now, it won't be as bad as it was. They start looking for relapse opportunities. Because I passed through that stage, or they even start planning to relapse in their head. And these are things that happen during mental relapse. So that the appropriate interventions for mental relapse. Important therapy goal is to help clients avoid high-risk situations. In our own setting, there's this basic, simple thing I tell clients. People, places, activities, and objects associated with substance use should be totally avoided. So they should identify and avoid their own triggers. And the teaching coping skills. If you've taught them good coping skills, they're able to navigate this mental relapse. And we must, at every follow-up visit, we must encourage them to have life outside of drug use, which is very important. Make new friends, re-socialization skills. They should make new friends and be able to have a new set of socialization, a new set of friends, so that they can live their lives outside of drug use. Then the physical relapse, which is the final form of relapse, which is divided into lapse and relapse. I'll define lapse as the initial drug or alcohol use, which usually leads to mental relapse of obsessive or uncontrolled drinking, thinking about using. Let me go back, say it again. Lapse is the initial drug or alcohol use, which usually leads to mental relapse of obsessive thinking, that craving comes so much, or uncontrolled thinking about using. Physical relapse is several relapses of opportunity to use. So those opportunities just keep coming, opportunities to use. Initially, the patient has a window in which they feel they will not get caught. It's something that nobody will see me. So the use starts and they continue using. As these opportunities come, they continue using. And physical relapse prevention, what do we do? Role plays, psychodrama, involving rehearsing opportunity situation and developing healthy exit strategies, exit skills. Sometimes during treatment, when we start teaching them relapse prevention, this psychodrama, rehearsing opportunity to use and exit skills, there are things that would help them further post-discharge, and that's the way to prevent physical relapse. And of course, the intervention is quickly at the level of physical relapse. The earlier the client goes back to treatment, the better the prognosis for such clients. Well, now that the patient has relapsed, it's gone back, it's completed the cycle from treatment to relapse. So in conclusion, evidence-based knowledge of relapse prevention enhances the need for person-centered approaches. And there's great need for therapists to be able to plan along the line of needs of their clients. Again, I will tell every one of us, one size does not fit all. Thank you very much. Thank you very much for listening.
Thank you very much, Dr. Koyejo. I think I got a lot of things from your presentation. And one of the things I got was the fact that we should understand that the factors that trigger relapse for children, for younger persons, will be different for older adults. And that was a very important learning point for me. If you have any questions, please just put the question on the chat box for questions so that we can post the questions to the presenter, please. Okay, Dr. Koyejo, someone has asked, what about the role of soul care in relapse prevention? Soul care in relapse prevention.
I didn't get it. Role of soul care.
Soul, I think caring for the soul in relapse prevention.
Okay, caring for the soul, like mindfulness-based mindfulness-based relapse prevention.
Okay.
It's yeah. You know, it's when we talk about emotional relapse, there are self-care, and your care for yourself could be emotional, could be psychological, and as much as you feel there's need for you to care for yourself, it would help you to be able to even navigate at the level of emotional relapse, which is the first stage of relapse. So it's very important, and mindfulness-based relapse prevention has been documented and evidence-based that it works. So there's need for us to do as much as we can in helping ourselves in the field or in area of self-care to be able to prevent relapse. Thank you very much.
Okay, thank you very much. Someone is asking this question: what are the roles of medication for relapse prevention? The role of medications for relapse prevention.
Okay. Thank you very much. We talked about some general factors that would, things like poor sleep, people that have comorbid psychiatric disorder. Of course, these are things that you should be taken care of. But the whole idea of, relapse prevention is about behavioral change, and is about giving the person skills, behavioral change, empowering the person with skills to be able to say no. Of course, when you've taken care of those comorbid situations, it would help the person to it reduces the risk of relapse. That is what I would say. Things like if patient has other comorbid problems, those things should be treated, and it will help the person to focus on relapse prevention. Thank you very much.
Thank you. The next question is actually not on relapse, but rather the person wants to know what happens when a client is not ready for treatment, despite efforts to talk him into it. What the person wants to know what he or she will do.
Well, the fact that a client is seeing you is a major milestone that, as addiction professionals, we should not just feel like, well, the client is meeting me. We should see that as an opportunity to help that client. The client might not have intrinsic motivation, as internal motivation to stop, but at least there's something bringing that client every day. And there's something called motivational enhancement therapy. And so you keep encouraging these clients. We keep through motivational interviews, which will help the clients to make that decision. The decision is owned by the clients, not us. So it's for us to do MET, motivational enhancement therapy, to help this client make that decision to decide to stop. But the fact that the client is coming to see you, that means there are external factors that are making the client come, and we should see that as a great opportunity. And even for me, treatment has started. So it might be very slow for a client, but at least the client is on the path of treatment. So that's something great, and we should work on that. Thank you very much.
Okay, thank you, Dr. Koyejo. So one learning point there is that the fact that the client is coming to you, or that the interaction that is happening between you and the client is actually a good sign in itself. And something that should consistently be sustained. All right.
Yes, we should encourage that. Yes, just keep coming, like they'll tell you in AA.
Okay. Someone wants to know, how would you go about to do relapse prevention with an intellectually impaired adult? Relapse prevention for someone who is intellectually impaired.
Wow. Well, relapse prevention for someone that is intellectual, that means there will be a level of cognition for that person to be able to decide to go and use. There will be some, it might not be, it's for the therapist to go to that level of cognition of that person, to be able to explain things to that person in such a way that that person would understand. Because if somebody is intellectually impaired, but the person can still go for drugs, can still navigate his or her way to go and take these substances. That means of course, you don't have to be a genius at all times. The person has some level of understanding. So that at that level, at that basic level, we should still come down to that person's level to be able to explain. We might not be able to use our do some personality some form of treatment, some planning like we do for other people. But we should still be able to simplify treatment as much as we can for that person to understand, and need for that person to know that these things would do the person might not be too good for such a person. That's what I would say. So for us as therapists, we must be able to meet our patients where they are and be able to explain things to them for them to make these decisions. Thank you very much.
Sorry, Babu, we can't hear you.
All right, can you hear me now?
Yes.
Okay.
Yeah, I can hear you.
Yes, go ahead.
In the case of a user who isn't ready to quit completely, is the use of a less addictive medication such as methadone an acceptable option? That's the user who doesn't quit completely.
Okay. Yeah, thank you very much, Dr. Barrow. Methadone is an evidence-based treatment in the field of addiction. So it's effective, and I want all of us to know that total abstinence might not be achieved in everybody. So we should stop setting those impossible goals for our clients. And if the use of methadone would help our clients, then clients should use those things and be able to function. You know, as therapists, it's not only about our patients quitting, our patients achieving functionality. It's important and it's progress for us. So if with methadone, which all evidence has shown that works in the treatment of opioid disorder, then we should go ahead and use it. So if it's evidence-based, and we should go ahead and use it so that our patients can achieve some form of functionality. We should know that even in the field of addiction, harm reduction is an acceptable goal, so that to help our patients to reduce harm, to reduce complications. So if methadone is what is available and what would work for our clients, I think we should go ahead and use it in environments where these things are available. Okay. Thank you very much, Dr. Bauer.
Now, the next question, is it advisable for a client who has relapsed for a number of times to continue receiving treatment in the same facility? I think what the person is trying to say, the person has relapsed severally in a particular facility. Should he continue receiving treatment in that same facility?
Well, there's need for reassessments for a client that have been relapsing several times. And sometimes I personally encourage clients would refer to another center if we are not achieving the goal, the expected goal. Yes, if it's after we reassess the client and we're like, okay, there's something this client might need we're not doing, there's something we're not getting right in this client, there might be need sometimes for you to just refer the patient to another evidence-based center that you think might be of help, that might meet the need of that client better than you are. So sometimes it's just good for us to be able to appreciate that, look, we don't have it all, even as therapists. So we could just refer to some other evidence-based centers for patients to seek help after several relapses in our centers. Thank you very much.
Thank you very much, Dr. Koyejo, for your very concise answers to the questions raised. We have some few questions left. It says, please, I want to know if methadone is available in Nigeria. If not, how are those dependent on opioids treated?
Okay. Thank you very much. Well, the last I heard is that methadone is available with NAFDAC, that's National Nigerian Agency for Drug and Food and Drug Enforcement Agency. But for an organization to have it, they really have to apply. But most centers don't use methadone in Nigeria. Very few centers use methadone in Nigeria. So what happens to our patients that would that have withdrawal symptoms? We help them symptomatically. We help prevent those symptoms of withdrawal so that they can have pain-free withdrawal. Then we do a lot of behavioral therapy and empower them with so much coping skills for them to be able to say no to these substances of abuse. However, few centers, very, very few centers use methadone in Nigeria that I know of. Thank you very much.
Thank you. Someone wants to know, you mentioned a few psychological disorders comorbid with SUD in the area of relapse.
Yes.
Any other ones outside of that? Aside of the ones that you mentioned?
Definitely. Yeah. Several, you could have, in fact, some people have full-blown schizophrenia, they could have depression, some people have bipolar. There are several psychological problems, co-occurring issues that could occur with substance use disorder. So it's like asking me for the whole of international classification of disease. So it's even other medical illnesses could co-occur as a result of the complication of the use. It could occur individually. So there are several other things that could occur in patients with substance use disorder, and there's need for us to treat those other psychological distress or disorders for them to be able to face their relapse prevention programs totally. So it's important that we treat those other things, that if you have to co-manage with people that are knowledgeable, with experts in those other fields, it will be good for you to do it so you can help this patient achieve the best outcome possible. Thank you very much.
Someone has just made a comment, which I think reiterates what you have said, that methadone is available in Nigeria. It can be procured from the Federal Central Medical Stores, Oshodi, upon approval from NAFDAC. I think essentially the same thing that you were saying. Then also someone had said that with the current situation in the country, although the person did not elaborate on what the current situation is, we don't know if it's the economy, we don't know if it's COVID, but the person is saying, is it one of the reasons for relapse for drug use? Drug use relapse, the current situation in the country.
Oh, well, thank you very much, Dr. Bao. The current, well, maybe we'll think about the COVID, the staying alone, social distancing, lockdown, economic depression, could be those things. Those are very distressing situations, like we've talked about. when there's distress, mental distress, emotional distress, this could even lead to surge in the use of substances, because people feel that people can't even go out to do their hobbies. So they are just locked up in their homes. And some might actually result into the use of these substances to help them cope with what post-COVID, what it would bring, what even during this COVID period, COVID-19 period, the dangers, the new normal. To be able to cope, some people would need something to be able to navigate this experience. So it could explain the reason why people feel that there's a surge in the use of psychoactive substances at this time. Thank you very much.
Thank you very much. Thank you very much.
Yeah.
Listeners, we appreciate Dr. Koyejo for her succinct presentation on relapse. I think she emphasizes the fact that we should focus on the fact that the process of treatment must also incorporate relapse prevention and relapse care. And we have been able to learn that there are triggers for relapse, there are phases of relapse. And an important learning point is not just looking at the physical relapse, but also at the emotional stages of relapse, and that we can intervene at the emotional stage to prevent many of our clients from progressing. Also, like we have said, the presentation will be available after this webinar, and then we can go through the points in the presentation, because there was a beautiful slide you gave there, Dr. Koyejo, where you talked about certain questions you can ask individuals when they are in the recovery phase. The other things we have here are not questions. They are just people saying thank you for your presentation, and also they are happy about the questions that you answered. I'm sorry, okay, we just have one. I don't know if we could, Martin, can we take one more comment or question?
Yes, go ahead. We can still take one or two.
All right. Okay, so it says I am currently working with Federal Medical Center Psychiatric Unit. Many times our clients experience relapse because of medications. How do psychiatrists really give precise medication without relapse? That question is not very clear. That question is not really very clear. I'm very sorry. I think you would have to ask that, rephrase that question, please. Says I'm currently working in the Federal Medical Center Psychiatric Unit. Many times our clients experience relapse because of medications. What medications? And how do psychiatrists really give precise medications? You would have to rephrase that, please. Someone else is just appreciates. Okay, then we have one more. How long should follow-up last? How long should follow-up last?
Thank you very much, Dr. Bao. Well, recovery is a lifetime thing. And follow-up what determines how long follow-up lasts is how well our patient is doing. Of course, initially, immediately after discharge, the frequency of seeing is high. And sometimes, and if the patient does well, you could even be seeing your patient once in a year, because it's just tailored according to response, according to progress of our patients. So I'm not able to tell you that, okay, do 5 years, do 2 years, do 2 months, but the longer this patient is in follow-up, the better for the client. Sometimes you might have to see your patient just once in a year, and it might just be what is good for that patient at that time. So there might not be a definite answer for that question on how long should follow-up last, because it's you tailor it according to the response of the client. But well, depending on how long the patient has used, you might have to follow up a patient for as long as 2-3 years before you even consider, okay, maybe discharging the patient from the clinic. And even at discharge from the clinic, you might even have to re-emphasize the need that the patient can come back as soon as it starts feeling all these early stages of relapse. So it's not like you are discharging totally, don't come back again. But you might actually have to bargain with your patient based on the response of the client to what you're doing. The response of the client to treatment would really determine how long our client should be followed up. Thank you very much.
Thank you. Someone wants to know, what's the role of the family in relapse prevention? The role of the family in relapse prevention.
Okay. The family, thank you very much, Dr. Bao. The family has active roles to play because you discharge the patient to the family. So they take up the treatment from you. And their roles might even be in the area of preventing triggers for this client, encouraging these clients, and well, based on the goals that we have agreed on, the family might have to help the client navigate the paths to achieving those goals so that the client does not get bored, and they are the first set of people the client might need to ask for help when craving comes. Sometimes just speaking to a family member would help our clients to overcome that short period of craving. So the family has a huge role to play in relapse prevention. I expressed emotion, preventing I expressed emotion, you know, by the family members would actually encourage the client, and the support clients get would help them sustain their recovery. Thank you very much.
Thank you. We have one more question. The person wants to know, what, in your experience, what do you do for individuals who relapse frequently and come back into the center again and again? I know you tried to answer it before, but from your own experience, what do you do for clients who relapse frequently? Is it a problem of the center? Is it a problem of the therapist? Is it a problem of the patient? Or what do you do?
Thank you very much. It's the problem. It's a multidisciplinary thing. You cannot hinge the problem at anybody's. That this is the culprit at this point in time. First thing is we will have to reassess the clients. Reassess what factors cause this relapse. Reassess if there are other comorbid illnesses. Reassess every other factors that could help that has led to this relapse. After the reassessment, then treatment starts again. So it's for us, and sometimes, like I said, you might even have to refer to another center if you think there's even in your proper assessment that you think, well, there's something I feel you need that we might not be able to give you in our own center. Why not try this other center that equally has evidence-based practice, and it would be of help? Because, and sometimes asking our patients what's the goal of their coming, because sometimes we get it wrong. We impose what we want on our clients, and it's not about us, it's about our clients. So when we impose those things and we are on them, they can't cope with it. But when we take it from where they are and help them from there, it might further help our clients. So it's about reassessing them and trying to know what is the cause of this frequent relapse. And sometimes you might need to refer to other centers, and it will really be of help to them. Not because you don't know it, but sometimes you might not have something that client needs that other center might have. So it's just humility to refer sometimes and that, look, let's try this other center and let's see how it works. Thank you very much.
Thank you very much, Dr. Koyejo. I think that's the final question for us. The others are just comments, thanking you for the presentation and thanking ISSUP Nigeria for hosting the webinar. So I'll go over to Dr. Martin now. Martin.
Thank you so much, Olajumoke, for the excellent presentation. And thank you, Bawo, for the excellent moderation. Thank you, participants. I think one thing is very clear, and that is the fact that we are committed to addressing issues with clients, especially the area of relapse and relapse prevention. Like the presenter said, it is very clear there is high level of relapse. relapse rate is very high. And there are a number of factors that contribute to relapse. And you will agree with me that a good number of them are actually beyond our control. That is the control of we, the professionals. And that is why we also need to understand this, that addiction is a complex issue. Relapse rate is very high. Therefore, we should equip ourselves in such a way that we don't experience burnout. And burnout is when, part of which is that we start blaming ourselves, for relapse or relapse cases. When our clients or patients relapse, we start blaming ourselves, but if we have better understanding that it may not just be we as the therapist, it will help to address that. And since these factors are beyond our control, it also means that we should not put ourselves in the position of the sick. And when I mean the sick now, because when we expect so much, or especially when we would have done so much, and at the end, our clients comes back to us again, by virtue of the fact that he or she has relapsed, then we may begin to ask ourselves whether we have done it right or wrong. But that notwithstanding, relapse is part of treatment. If you look at the Prochaska and the Clemente stages of change model, from pre-contemplation to relapse and so on, you just discover that it is part of treatment. So irrespective or despite how many times our clients may relapse, let us see it as part of treatment. And that will also help us in dealing with issues. And just like the presenter said, we may just have to reassess our modalities or refer to other centers as the case may be. But one thing is very clear, and that is the fact that we should try to see addiction as the problem, where every other person comes around to address the issue. And that is why at times I advocate addiction as adaptive challenge as against a technical problem. Technical problem, you can fix it. Your car has a fault, you take it to the mechanic, it's a matter of replacing the parts and so on. But when it comes to addiction, it's a different thing entirely. So how much of this we have understanding of, the better for us, so that we don't see ourselves as the solution providers. When we see ourselves as solution providers, we are eventually put at the center of the problem, where every other person will be looking at us for us to fix it. But if we see ourselves as one of the stakeholders or components of addressing the issue, you will have people around, of course, community, family members, socialization agents, and so on, coming around the issue. And that is how to assist or support the client. But if we see ourselves as solution providers, one might be overwhelmed, and in that case, it becomes very difficult for us to manage, and we experience burnout. So that is the essence of acquiring knowledge, so that we know that we definitely should do what is best for our clients, but at the same time, there are things beyond our control that will eventually lead the client to relapse. There is just little we can do when it comes to relapse prevention as individual or as therapists. So having said that, it is also very clear from today's presentation that relapse differs for sex, for age, for substances of abuse, and so on, and that is key. So at this point, once again, I want to say that Olajumoke, you've done a great job. We are so proud about what you have done, and we are looking forward to another session again. So at this point, let me, on behalf of the Board of Trustees, the Executive Council of ISSUP Nigeria chapter, I want to say a big thank you to the speaker once again. And of course, for a job well done. I'm sure that we have been very well educated and on this very important topic. I have no doubt that we will, at least from today, do provide better service delivery than we have always done by virtue of our participation in this session today. So to our esteemed participants, thank you for joining us, and thank you for your wonderful questions. Please keep the date again, that is 26th of November 2020, so that you can join us again in another very interesting session. Also, don't forget to join the ongoing ISSUP African Regional Conference. So you can visit the ISSUP website, or you already possibly may have received the newsletter, log in and be part of it. I must also quick to add that in the next session, Dr. Bao James will be speaking at that session. So wishing you all the best in the next presentation or in the next ISSUP conference session. That is precisely on the 6th of October. So to ISSUP Global, we are grateful for your support. We cannot just thank you enough. And to everyone, time is not always on our side. I say thank you all and stay blessed.
Thank you, everybody. Thank you, everybody.
Bye-bye, everybody.